Welcome to Behind the Best, where we are going behind the best in sport and performance. I'm Talia Lazarus, and today we are going to be busting some of the biggest myths surrounding lower limb injuries. Should you exercise with an injury? I'm guilty of that. Are some injuries truly just part of getting older? And what are the most common misconceptions that stop people from recovering properly? And today, joining me are two incredibly experienced consultants from Fortius Clinic. We have Mr. Pieter Doha, consultant foot and ankle surgeon specializing in advanced arthroscopic, which is keyhole surgery, and sporting injuries, and Mr. Osama Aweid, who is a consultant knee surgeon specializing in the full spectrum of knee conditions. Well, basically, if it involves a knee, here's the man to ask. So, you know what? Let's get straight into it, guys. And can either of you or both of you give us a quick overview of the types of injuries that you see most commonly in your practices?
Thank you, Talia. So when we look at a foot and ankle spectrum in lesions or in problems whatsoever, we shouldn't look at it only from a trauma perspective. But what we see in the world of athletics, for example, is that every condition is linked to something sport specific. What do we mean by that? For example, there's an entity called a footballer's ankle. There's an entity called a dancer's ankle or a dancer's foot. There's a fracture called a snowboarder's fracture. So every type of sport is linked to a kind of mechanism that can induce injuries. A footballer can be twisting its ankle, and a dancer needs to go in pointe, in full plantar flexion, with all the problems that go with it. And you can twist even in a ski boot your ankle and have a particular fracture there. So there's a range of problems that are mainly linked to a kind of sport-specific condition. Now, what we see normally are ligament problems, tendon problems, cartilage problems, and some stress fractures, especially over the foot with runners, with military personnel, and so on. So it's kind of an overview that we have to look into. But by just listening to the mechanism and to what happened exactly, we can already know a lot on how to guide further the strategy of that condition.
I'm really excited to keep going because I think I'm going to learn so much. I'm just listening to the two of you now and I'm like, oh, it's all burning. So I'm really excited. And now I need to ask, why do you think so many myths exist around lower limb injuries? Are they coming from social media, gyms, old coaching advice maybe?
Well, obviously, myths exist anyway, but when you look at foot and ankle, everybody has something. And in a foot, you have 32 bones. So you can imagine the spectrum of problems you can encounter. And that's why many people are looking into an advice. And from a surgical perspective, it's quite clear what are the indications. But there's so much out there. There's cryotherapy, there's acupuncture, there's osteopathy, there's chiropractic, there's rehabilitation in particular areas, there's magnetic current type of treatment. So there's a whole range of treatments that do have pros and cons. And people want to investigate in that, want to look into it and see what it does prior to going for any more invasive treatment. So I wouldn't say myths, but every other week almost a new treatment pops up, and it's our job to kind of guide our community into what works, what doesn't work, what is indicated, and what is maybe a myth, where we work obviously through a research-driven perspective. We can actually check if it works or not, and that's our principal job, not just to treat by default, but to offer a kind of being a wingman or a wingwoman to our community. And I wouldn't call it myth in itself, but it's a real privilege for us to kind of not just look into what's good for you, but also look into how to prepare for a surgery, how to guide the rehabilitation further. So from A to Z, that whole package is what we should do and what research guides with that.
I would say knees especially, I think myths come from the fact they have a condition or a problem that a lot of people have. So knee injuries and conditions are really common. I think it's reflected by the fact that we have how many knee surgeons here? So it's the biggest number of the subspecialties in orthopedics here. I think knee surgery is the biggest, and that reflects the number of injuries we see. So that creates myths, I think, when something's very common. People all have their own say. I think especially more recently with AI as well. So patients will get their MRI report and they'll put it in online and they'll ask AI, whether that's ChatGPT or otherwise, okay, I've got this, my report says I've got a meniscal vertical tear of the medial aspect posterior horn. How is that managed? So AI is very good in terms of sifting through the science, and it will give you an accurate answer, but MRIs are good at telling you what's wrong in your knee, but how badly injured that ligament is or that meniscus depends on the assessment on examination. So until for an ankle specialist or knee surgeon puts their hand on the knee, examines it, that's how you know how badly something is injured and what treatment it needs. So I think that's the biggest myth. I think the other myth to mention as well is what I said earlier about, if I have, especially in knee surgery, I think a common one is if I get arthritis or wear and tear, the only treatment is a knee replacement, and there's nothing you can do until you have a knee replacement. And the problem that creates is we've seen research that shows that the use of opioids and painkillers, especially ones that can have a bad effect on your body, on your kidneys, we've seen that people are overusing these because they think, look, there's nothing I can do other than wait for this one treatment. So that's a very important myth that has to be addressed. And especially, I think we spoke about it earlier, training right as well. So, doing the right exercise and rehab actually can address most knee injuries. So that's very important to kind of one of the myths to bust. I think it's the same in ankle as well, isn't it?
Yeah, and actually it's nice that the two topics chosen were knee and ankle, because there's so much relation between them. We always see these conditions as an entity, like I have a foot problem or an ankle problem or a knee problem. But the dynamical part of it, the chain of movement, is what we're looking at. And if you have, for example, an O-shaped leg where your knee goes in an O-shaped position, you will easily trip over your ankle, because that position from the knee radiates to the ankle, and you will have less stability, or you have easier stress fractures on what we call the metatarsal 5. So the way your lower limb is being shaped, we have to address the whole entity of that and not just look at the articulation itself.
I think I would agree with that. And again, going back to going online and Googling your scan results, you may pick up a problem in the knee, but if you don't address the environment around the knee, what's driving that problem, what's triggered the injury to the meniscus, there's usually something either higher up in the hip or in the ankle or in the biomechanics, what we call, that's resulted in the injury. So people always think, the meniscus, the cartilage is the shock absorber of the knee. Actually, the muscles are the best shock absorbers of the knee, and that's why developing strength there will offload your knee. And clinicians who are good are ones who also screen the joint above and below. So if you find that someone's been diagnosed with a knee problem, it's very important to screen the ankle and the hip to see if there's anything there that could be contributing to this issue. And then the benefit of us, this kind of clinic, is that we all work very closely together. So if I was to pick up anything in the ankle that's contributing to the knee problem, I can refer it to Pieter. He can have a look at it. And the same thing, I always constantly get referrals from Pieter as well. If he finds that, I've seen a patient with an ankle problem, there's something in the knee that's driving or overloading the ankle, I'd be happy to see that patient and address it.
It's really interesting because you were saying about, especially with knees, but obviously with all lower limbs, is there's a lot more people doing a lot more pivotal sports and things like that, and not everyone's as strong to be doing all these different things. And that's, one of the reasons we're seeing more injuries. And as someone that's had knee surgeries myself, even more recently during pivotal sport, I was playing a paddle tennis game and I heard a pop in my knee, and obviously instantly thought the worst because I've been through it all. Well, it turns out that my quads just aren't strong enough at the moment. And again, thank God, it's all okay, but it could have been worse. And it just goes back to everybody that's not strong enough, but playing all these different sports and all these different things these days. But people need to probably be training, especially their lower limbs, in a very different way.
And it's not just the quads. I mean, we know there's research that the glutes are really important. So the biggest driver for ACL injuries is how you're landing. So if your knee goes into valgus, or what we call caves in when you're landing, that's the position where your ACL is at high risk of being injured. So actually, if you address the whole chain, as Peter was saying, if you develop your glutes, that'll stop the knee from caving in, and therefore you reduce the risk of an ACL injury. So there's a lot of work being done in the UK now to try and avoid injuries by training athletes, anyone involved in sports, getting them to warm up by training the glutes and warming up the glutes, so that when they're landing and jumping, there's not that strain on the ACL. Because as you know, it's all well and good doing ACL surgery and fixing people, but the key thing is if we can stop these injuries. I think that's the most important goal for us, and long term, I think.
And you will see that, for example, in elite sports, if you read the papers for particular conditions, we will wait 3 weeks before we perform surgery. It's not because we have a waiting list. It's just because we need to make sure that the muscles are activated prior, so that you can fly through your rehab afterwards. So by waiting, you win. And that's a principle that people need to know, because sometimes you don't really recognize that. And it's that muscle activation that is so essential. On top of that, since you touch on Padel, when you hear a pop in Padel, most of the time it's your Achilles tendon.
I've done it.
Yes, there you
in
go.
Padel.
There you go. So we know, for example, that Achilles tendon ruptures in the ankle are very, very linked to tennis players in particular age groups, and that's because of the mechanism. Now, since Padel became so popular, it has increased 3 times more. And the reason is the mechanism. You play tennis quite horizontal, but Padel, you have to go down with your racket and play upwards, especially when it comes from the wall back and so on. So you kind of lift up the racket from low to up, where in tennis you stay more horizontal. So because of that, you actually rupture your Achilles much more. So with that, any preparatory activation of muscle and tendon units actually are incredibly important in a preventative way.
So basically, leg day is actually very, very important.
Absolutely.
It is, yeah. So I think that's kind of an interesting thing to always to mention in terms of a misconception. But the key thing with the runners we see is they're not conditioned overall. So it's not just strength, they're also very tight. So if the whole chain is extremely tight, then again, you're overloading. That tension is transferred to the joints, and you're more likely to have a joint or a tendon injury. So flexibility as well as strength is really important.
So speaking about things like this, and then injuries and tightness, is the phrase "no pain, no gain" ever actually true? Should people still be exercising through pain? I say that kind of a bit cautious, because I know what you're two about to say, but I do tend to exercise even when I'm in pain, and my mind will say stop, but I just keep going.
Yeah, well, that's a really complex question. Because it has different kind of pitches. If you have a ligament tear or call it a muscle tendon tear, you can kind of go through it, because there's a principle called mechanotransduction that by loading it, it kind of heals. If you have a fracture or a stress fracture and you go through the pain, you're ruining it. So it really depends on what you have in order to guide how your loading ladder should go and go through it. But in general, obviously, with an injury, you first need to reset a bit and then have an expert guidance around that, not just for treatment itself, but for the progress towards a road to recovery. So I would say it's a kind of bit more detail around it than just yes or no.
I think one phrase to sum that up is train smart and not hard. So you just don't just go hard. You got to pick the right exercises and load the right muscles. So that's kind of a summary, I think, of what you're describing there.
Yeah, and also I think in clinic we see the whole spectrum of it. And for example, I've seen rugby players walk in with a broken leg, and I've seen other people with less conditions with severe pain. So you also have to realize that the perception of pain is very different. And that is not that some are tough cookies and others are not. It's just the way we are built. And it's kind of our job to have the look and feel on that and really guide that in the right way on an individual basis.
I think that's important as well is, especially when I was talking about the other group of patients that I see, the early wear and tear, early osteoarthritis and active people. They'll often say, look, it's too painful, I can't run, I can't train. We've already explained how actual muscle strengthening and exercise can help offload the knee in arthritis. And so often patients will say, well, I can't exercise. So then you'll have to, again, as I said, train smart. So there are so many other non-impact aerobic exercises that you can do. So exercise, bike, swimming, rowing. And as you talked about earlier, so strength training, so leg press, squats. So all of that is what we call non-impact strengthening exercise. So even if you have pain in the joint, if you pick the right exercises, you can train, which is the treatment, strengthen yourself without inducing pain.
I feel like I'm in physio all over again. I know I'm enjoying this a lot. I'm refreshing my own memory, which I clearly need to do. And then, we were just talking about this, injuries. Is rest always the best treatment after an injury?
Initially, obviously, yes. But in French, they say, le mouvement, c'est la vie. It means that by moving, you get better. So rest initially, yes, but movement is the key and exercise is medicine.
So everywhere in the world, it's maybe a no, but in France, keep moving.
Yeah, and you will see that people who are in pain, for example, by moving, they get better, like Osama said. It's the contracture of the muscle and the complexity of that contracture, actually, that gives a lot of pain. And not just the rehabilitation can help, but the nutritional supplements as well. So again, it's looking at the whole picture.
Again, just to add a summary, I remember when I was doing my MSc in sports medicine, one of my tutors told me, if you ever have an MCQ in the exam and you're not sure what the answer is, pick exercise, because usually exercise will cure everything. So you're probably likely to get the answer right if you tick on the exercise box.
That's a good one.
Yeah, so.
It does. It cures it. When you're sad, people usually say, go exercise. Even when you're unwell, sometimes people go exercise. Yeah. So I guess exercise is just the key to everything here.
Totally. I agree with that.
And then, do injuries really heal slower as you get older, or is that just a complete oversimplification?
Well, we have to watch out here what we say. No, I'm joking. Look, there are age-related reasons and protocols that differ. Not just age-related, but also gender-related. When women go into menopause, for example, you need some supplementation of estrogen and type of hormones to keep the kind of bone density in a quality way. So it's our job, again, to identify all these risk factors, whether they're intrinsic or extrinsic, and make sure we can tailor to the needs of that patient. But age in itself is not a problem. We see, actually today I saw a 75-year-old lady who just fell from the ski slopes in the Alps and broke her leg. Super fit, strength excellent, flexibility excellent, agility still full on, VO2 max perfect. So I would say that the age is not a reason anymore to kind of defer treatments where we would say prior, you're too old to have this treatment. Not anymore. But specific conditions around, for example, menopause are.
So that's why I did my ACL as one of many other things I did, because I'm hypermobile. So but that is an interesting question, because you do hear about people that are hypermobile having more specific related injuries.
That's why even it's especially important in hypermobile patients to do those warm-ups, to avoid the knee going inwards, that position where you're at risk of damaging the ACL. And as I said earlier, there is evidence that doing those warm-ups 2 to 3 times a week before every sport, especially warming up the glutes, prevents people from having those injuries.
So then let's move on, and we can look at just specifically the foot and ankle for a moment. When people say it's just a sprain and it'll heal on its own, how true is that?
Well, I can reply with one quote, and that is, there's no such thing as a simple ankle sprain. Now, why do I say that? When we look at the data, let's just call it the way it is. In the world of emergency departments, the ankle sprain, or the so-called ankle sprain, I'll tell you in a minute that actually doesn't exist, but that's another story, is number one in the world. So this is the most common entity in the world of emergency departments. It is the number one entity in the world of sports globally. So ankle sprains are incredibly frequent. And it's the number three in football, for example, after hamstrings and knee conditions. So we're talking about something that is like a conglomerate of things. We call it an ankle sprain, but I always, when we teach at university, I always say to the residents and the fellows, I say, when you are in the emergency department and a patient with an ankle sprain comes in, if a patient would come in with a knee or a shoulder condition, would you call your superior and say, look, I want some advice because there's a patient here with a knee sprain or with a shoulder sprain? They said, no, we don't do that. When it's instability, we call it. When it's locked, it's probably cartilage or swelling or whatsoever. So every entity has a diagnosis or a differential diagnosis. So we don't talk about knee sprains or shoulder sprains anymore because we detail it. But for some reason, we still always talk about ankle sprain, which doesn't exist because it's or an effusion with cartilage, or an instability with the ligament, or a snap while looking backwards and having a tendon tear. So we have to get away from the ankle sprain, but because it's so common, it makes sense that we give it a name. So to answer your question, there's no such thing as an ankle sprain, and it's our duty to detail that a bit further in order to do the right thing and kind of go further and not like the knee and the shoulder.
That's actually really interesting. I didn't realize there was no such thing as an ankle sprain, but now I know.
There you go. Yeah,
you do occasionally see patients being referred with knee injury, saying soft tissue knee injury or knee sprain, but much less common, you're right, ankle. Yeah.
It's actually interesting because when I had my accident, and obviously it was all focused around my injuries with my knees, I definitely did something to my ankle, but to this day, I couldn't tell you what it was, but there was so much wrong with my knee, the ankle. I think I don't even think I registered that I knew there was a problem. And now I look back, it just whatever happened, it just healed on its own. But it is interesting that when we're looking at things like injuries, when should somebody choose rest versus rehab versus seeing a specialist for an ankle injury?
Well, what you just touched on with having a knee and an ankle condition, it's actually so true because you have to look at it from a kind of anatomical point of view. A knee is what we call an incongruent joint, meaning if you take away the stabilizers, it just pops out like your ACL.
Oh yeah, it did.
And the knee has developed some menisci, which are like the sponges to kind of absorb the energy because it's incongruent. An ankle is a congruent joint. So even if you take away the stabilizers around it a little bit, the bony anatomy still protects you a little bit. And that's the advantage, but also the disadvantage. Because if you're unstable in a knee, you'll feel it immediately and you'll say, I need to do something, like you just said. But in the ankle, you can kind of deal with it, cope with it. But over time, that instability will get back on us and will give these problems that we encounter. So the ankle is a bit of a slow, problematic joint in that regard because it comes later. And with that, all the other issues arise. And it's our job again to look into that, look at the alignment and see how we can make sure that over time you don't get in trouble. It's a very forgiving joint in the beginning, but not at the end.
No, that's fascinating because you're right. When I did my knee injury, it felt like my knee was hanging off, falling off, and turns out it kind of was with everything that happened inside. But I didn't realize as well, if you were to do something obviously not similar, but to your ankle, it's still very stable.
Yeah, and to answer on the second part of your question on rehabilitation, it's also a very different concept because there's muscles around the knee. There's zero muscles around the ankle. only tendons. So the principles of rehabilitation are very different. And that's something that, again, is our job to guide in that perspective as well. You can't just activate a muscle around an ankle if there's no muscle. You see what I mean? So these are kind of myths and misperceptions that we go back from your first question. But again, that's where the specificity comes in. And that's what we all love about our job, because it's never the same. It's always different. And it's nice to be a guide in that road or that journey.
So then let's move on to knees. It's my favorite, no offense.
None taken.
And
Pieter didn't tell you that he used to do knees as well, so he does. He's quite an expert in both. So
well, I can tell. I can actually tell.
I'll let you jump in whenever you like as well.
Well, there we go. And I have to ask, and this is definitely one of my favorites: is running actually bad on your knees, or is that a myth that won't die? And I just have to say that my knees, whether it's what I've been through or not, my legs don't like running. So I'm now going to move on to the specialist.
Yeah, so I think we mentioned it a little bit earlier. So it's all about how much, and the volume. The studies that show that the ultra marathon runners are at higher risk of osteoarthritis. I think it's 20%. And the ones that don't do run at all, again, that same high risk of osteoarthritis, where recreational running is a little bit less. So the risk of arthritis is less than that. So it can be bad. So in answer to your question, in summary, if you're doing masses of volume, yes, it can be bad. But at the same time, as we were saying, it's all about the environment around the knee as well. So if the conditioning is there, the flexibility, there's less load on the knee when you're running. If the muscles are strong around the knee, leg day, then the muscles are shock absorbers, so that takes the pressure off the cartilage in the knee, and the risk of injuries is less as well.
Okay, so you kind of need to be, well, not you need to be, but if you want to run quite a lot, you would have to keep your legs pretty strong then.
You have to have that environment there, you have to have the conditioning and strength there. And it's not something that you build up slowly as well, the volume of running and impact. Where injuries happen, especially, for example, after an ACL reconstruction, is if a patient's told, go back to running immediately, and they've not gone through the criteria-based rehab or the testing to make sure that their knee is actually ready to run. Are they able to hop on that single leg in a controlled environment? Do they have the symmetrical strength on either side? So it's very important that the knee is ready for running before you run. We tend to, usually when we do see beginnings of wear and tear in the knee, osteoarthritis or cartilage, we tend to find that impact sports become an issue. So we like not to tell patients to completely give up running, but we sometimes encourage building up a volume of non-impact aerobic exercise into their aerobic routines. So, as I said earlier, cycling, swimming, rowing. I kind of, the way I usually describe it to patients, if you imagine you have a tire for life, and that's got to 20,000 miles or however much, you don't want to kind of use up all the miles immediately. You want to, you want that to last your lifetime. So if you bring in things that aren't going to wear out the tire very quickly, then that'll give you a healthy knee for a long time. So it's good to have a variety or spectrum of aerobic exercise.
Or you can go to Osama and change the tires again.
Yeah, exactly. That's the thing, we want to avoid replacing the knee, because that's always the last resort. A full knee replacement, the problem is you kind of lose the feel of the knee. You always know you've had something done. Whereas all the other procedures or treatments that preserve the knee, the aim is to keep the feel of your knee as a native knee, so you don't feel like you've had something done. So it's the realignment surgery, the meniscal repair surgery, the partial knee replacements. Even though you are actually replacing the knee with a partial knee replacement, the benefit is you're keeping all the ligaments, the ACL, the PCL, and the envelope, the soft tissue envelope of the knee is still there. So more recently, we're beginning to class partial knee replacements as a preservation operation as well now. So yeah, we try and avoid at all costs the full knee replacement. In the right people, is a good operation and it gets good results. But usually patients who want to pursue moderate to high intensity exercise, it's a bit unpredictable how much they can do when you have a full knee replacement.
See, I didn't realize that, and that's something I've actually just learned, because I know I've had 2 surgeries. One was meniscus repair and the second one was an ACL surgery. And a lot of people ask me now, do I still feel pain or do I know? And there are some days where I will walk around and almost forget I've had 2 major knee surgeries because I just don't feel, I mean, some days, believe me, I feel it enough, but there are some days where I feel nothing and I forget. And well, you've just answered that question for me, so thank you.
You're welcome.
With regards to running, would you recommend somebody run a half marathon a year after an ACL reconstruction? Because that's what I did. I ran a half marathon a year after my ACL reconstruction and I was training. I started training while I was still in physio, and a lot of people said I was crazy for doing it.
Yeah, but you also have to look at the demands. Running is perfectly okay while your stability is back, where other types of sports like deceleration, cutting movements, rotational movements might take longer before you can really engage at a higher level towards it. So it's the sport-specific demand of it that is really important. So in running, it makes sense to say, I feel comfortable with that. Once, like Osama said, you've reached all your criteria, where you probably need a bit more time and a bit more muscle quantification for other types of sports.
So essentially, if your physio has told you you've passed all the tests and you can run, and the key tests are, are you beginning to get near enough equal strength in both knees? Do you have that control and balance when you're hopping on a single leg? With the interval runs, short runs in a controlled environment, are you safe? Are you getting pain afterwards? So there's lots of criteria and tests that you have to pass to be able to run. And if you've done those, then after an ACL operation, it's fine. It's the cutting and the change of direction which takes longer.
So can we ask you a question,
Yeah,
Talia?
you can ask me. You can ask
not
me.
Done? So on that particular note, when did you start feeling normal again and ready to do sports after your surgery? Can I ask you that?
Yeah, it's a really good question. I don't know. I don't know if there was a single moment where I threw myself into my physio. I was dedicated. My quads got huge. I was dedicated because, after the first surgery, the meniscus repair, I trained, got stronger again, then had the ACL reconstruction 6 months later. And I don't know, actually. There are still some things I'm too scared to do. And I don't know whether that's right or wrong, but there are still things I'm scared to do. So whether it's, when I'm watching football, for instance, and I know someone's come back from an ACL injury, I respect that so much because I've been through it. So I don't know when there was a moment. I know when the half marathon idea came to me, it was about 10 months after my ACL reconstruction, and the idea was put towards me, and I messaged my physio and I said, you think I could run a half marathon in 4 months? And he said, yeah, why not?
Because you actually just hit the nail. It's all about getting back and about recovering, and we have data to support that and reach these criteria. But when are you feeling ready? As an athlete, that's the final stage, and that's individual for everybody. And it's just like you mentioned.
Yeah, no, and I agree. And that's probably why when I then started training for a half marathon within the same year of an ACL reconstruction, so many people told me I was crazy, but I didn't think I was. So I was obviously ready to do it for myself.
And we often find after ACL reconstructions, it's not actually, I think that stops people going back to the sports, isn't the fact that the knee objectively feels less stable or that there's a problem in the knee. Having an ACL operation and the recovery is so intense on a person and it's so long that there's that fear, I don't want to do this again, there's no way I can go through this again. So it's more of a psychological factor, I think, and a psychological driver that I think scares people, or that is responsible in people not returning to the sports, as opposed to an actual problem in the knee itself. So I think, especially in ACL surgery, because the recovery is so long, it's a year to fully recover.
Yeah, I can definitely agree with that.
Yeah.
Believe me, if I've had scares in the past, I think to myself, I really don't want to go through that again. No, I agree. So then let's move on to meniscus. And do you need surgery for every meniscus tear, or are many better treated conservatively?
Yeah, so it depends on the type of tear, as you know. So as Peter asked you, do you mind if I ask you again what kind of meniscal tear you had?
I had a bucket handle tear, 60% of it.
Yeah, so really that's a spectrum of severity of tears. That's one of the most severe tears. essentially a bucket tear is when a part of the meniscus is lying in the wrong place, and it causes a mechanical block to movement in the knee. And also, if the meniscus is lying in the wrong place, or most of it is sitting in the wrong place, the function of it isn't there. So its function in distributing the load in the knee isn't there anymore. And so that's one of the operations that needs surgery. And usually it needs surgery quite quickly, because if there's a mechanical block to extension and to the range of movement in the knee, you can very easily get stiffness. And stiffness if left for a long time, can be very difficult to treat. On the other end of the spectrum, you have the what we call the degenerative tears. So a tear that happens with minimal trauma in a environment where that knee is beginning to wear out already, so the cartilage is already thinning out. So those are the less severe tears. Many years ago, orthopedic surgeons used to operate on a lot of menisci. So any meniscal tear, whether it's a degenerative tear or a serious tear like the one you had. But there's lots of evidence coming out more and more recently that the degenerative meniscal tears mostly don't need an operation. They can be managed with physio or injections. When COVID hit, that was interesting as well, because we found a lot of patients who are on the waiting list for meniscal surgery when we shut down for a while and then reopened again. So they had to wait a little bit longer. When they were contacted and asked, look, do you still want your operation? A lot of them said, actually, my knee's okay. So that's kind of more evidence pointing to the fact that meniscal tears aren't all the same. Certain meniscal tears can settle and improve without an operation. The other serious meniscal tear is a root tear. So you can imagine the meniscus is a C shape. So if the whole attachment of the meniscus is gone, then again, that defunctions the meniscus. So the role of the meniscus in distributing load is not there anymore. And so in an acute injury where the knee is already in a good shape, so there's no arthritis there to begin with, those are the ones that you'd want to repair at an early stage. What we call a radial tear is quite serious as well. Again, because that cuts through the fibers and across the meniscus, and again defunctions the meniscus. I think those are essentially the main ones.
You see, you don't need AI. You call Osama.
I know.
That's it. Yeah.
Yeah, but that's the thing. The other thing is pain as well. So if you had an MRI and it said you had you've got a serious or full thickness root tear, you put that into AI. It'll tell you, okay, you need an operation now. But actually, if you see a specialist in clinic and they examine you, and they ascertain that you've already had wear and tear in that joint, you got no pain in the knee. There are a lot of factors that determine whether you need surgery. It's not just the finding on a scan. It's the clinical examination. So.
Sounds like there's a lot of factors, but there's also a very fine line between when and when not to have surgery.
That's where we come in. Otherwise, Dr. Google can take over. And it is more than just the entity or the classification. It's about pain, about alignment, about stability, about effusion, about comorbidities, about historical family diseases. It's about diabetes. It's about so many things that every time we're part of the puzzle and we puzzle together. And it's a privilege for us to be part of that journey. But it is, yeah.
I like that, part of the puzzle. I like that a lot. And then one more with regards to knees. The phrase when people say, my knee clicks, so something must be wrong. Is that always something to worry about, or is it not? Personally, if mine clicked, I would be very worried, but...
Yeah, so I mean, exactly as reiterate what Pieter just said. So it's the clicking is just part of the puzzle. There's so many other factors that determine if clicking is a problem. Often it could be something that's not a worry. It could be due to the natural movement of ligaments over bone in the knee. But if it's associated with, as Pieter was saying, swelling, locking, catching, pain, problems in other joints, then there could be something serious. So it all depends on the history. So what the patient tells you about that clicking, what it's associated with, and when you assess the knee as well. So that's what can tell you whether it's a serious thing or not. But usually most patients with clicking, it's a benign thing that we see as opposed to a problem or a serious thing.
But if you're worried, come see an actual specialist. and actually have it looked at properly, because there could be lots of people walking around, let's say, with injuries that are, even ankle, as you were mentioning before, far worse than they think.
Absolutely. And the misconception is that MRI shows everything. MRI is a static examination, which is phenomenal in order to look at particular entities in your joints. However, it's nothing dynamical until now. Maybe it will in the future. And the dynamics of joints is not to be underestimated. So we have to bring it together.
Yeah. The use for some MRIs, for example, in knee surgery, it'll show you if there's a ligament injury, so the MCL is injured or the ACL. But it won't tell you how badly injured it is. So the only way you can tell that is by examining the knee and seeing how loose that ligament is when you examine it. So it can guide you as to where the problem is, but really, ultimately, it's the assessment that tells you if this injury needs an operation.
Yeah, I'm having a lot of flashbacks because you said
Sorry for that.
No. It's good. It's therapeutic for me because you just said it. You know, depending on my MCL was a grade 3 rupture. I did my ACL, my MCL, and my cartilage, my meniscus. And when I said earlier that it felt like my knee was falling off, I mean, I remember the day of the accident. It was just hanging, and it was for a while. So obviously that would have been a no-brainer. Looks like that's going to be, surgical for something, but it's really interesting when you say it in that way. And then I want to ask, what is one evidence-based tip that you would give to people to prevent foot, ankle, and knee injuries?
Well, it's actually quite simple. If you have deep pain, if you have effusion that shouldn't be there, and if you have mechanical complaints like locking, these are 3 major red flags to look for help. Everything's forgiving for the rest when we talk about foot and ankle, but basically limping is also a feature that we don't underestimate. People just don't limp from itself. So that means that the load absorption is not there. So these are some clinical entities that can really guide you. If after a few days you still have these, then you should look for further imaging or at least some further expert help.
And then what about preventing the injuries? What tips would you give to people?
Like Osama already said, it's about flexibility and strength. And if strength is out, more in sedentary people or people who have been immobilized for a while, you really have to watch out for re-injury, because strength is a major, major condition, not just to rehab well, but also to prevent.
It just goes back to what I said earlier, exercise cures everything. So it's really important to pick an exercise and stay active, but exercise smart. So pick something that you enjoy and something that doesn't aggravate your joints or your pain. I mean, a personal example again in COVID, the gyms shut down, and everyone got lazy. We stopped exercising, and all of a sudden I noticed I started to get anterior knee pain, so pain in both knees. I never had it before, and I was like, "What's this?" It's really it's become really bad. And basically, essentially, it's when your quadriceps, weaken and waste, you overload the knee. Your tracking of the kneecap gets worse, and then you start to get pain. So I was noticing when I drive, all of a sudden I couldn't sit down for long periods of time. I had to move the seat back, to offload my kneecap. And as soon as I went back to exercising, it went away. So there wasn't anything physically wrong in the knee. So sometimes you don't actually have to have an injury or damage to the cartilage or meniscus. It could be a biomechanics issue that's driving the pain, or a strength issue, as Peter said. Do you remember your lockdown, Peter?
Oh, very
what did
much
you get
indeed.
up to?
But I think you touched on a really important question there, because we all know that leg day is not the day you look forward to, because the next day you can hardly walk the stairs. But it is essential to incorporate it in your protocol for that particular reason. And it's an important message for everybody out there that strength is essential in your whole pattern of rehab, or just a gym for your longevity or healthy lifestyle, because it's a bit more boring, it's a bit more painful to do, but it's super, super important. We love the strength training of upper limb. We love to do all sorts of stuff, but we kind of try to avoid the leg day for that particular reason, and we shouldn't.
I want to ask you, Peter, a question. So you have 4 kids, if you don't mind me saying. how do you, I'm sure there's a lot of people out there who have really busy lives, they got family, kids, work. How do you incorporate exercise and training into such a busy schedule?
Well, actually, I'm not the role model because I should be doing it more from a role model perspective. But the work keeps us busy, the work. Yeah. However, I do have a girl who's looking into a professional football career. And as you know, in the female athlete, ACL, for example, is a major problem compared to the male footballer. And for that, we know that there's up to 33% of prevention possible. So I give her all these exercises, and she takes them very diligently, because a lot of girls in her team suffer from ACL and have now picked up that protocol as well. So on top of that, for example, on an ankle perspective, I remember a few years ago, she came in with her toes terribly injured and blistered and bruised. And she said, "Dad, can we do something about this?" And we went on the road, and actually we went to 200 clubs with our teams and did foot scans of all the female players in Europe. And that data has now been given to the major apparels, and now there's a female football shoe. So from small things come big things. And with that, it's important for people to know that you don't always need big dreams. You can just look at a problem, team up, and make it happen. And now we can hopefully not just treat toes better in the female athlete, but actually prevent better. It's to be proven, but it's worthwhile the effort. So yeah.
So for my budding football career, I need to go get myself some actual female football boots then.
You might.
But I think in terms of, if you're someone who's really busy and you can't fit in exercise, there's always a way. I mean, one is an easy way is incorporating exercise into your travel into work. So if you're a cycle ride away, that's an easy win. But some people obviously take the tube, and so that's not an option. I mean, for me, a simple example. So I finish very late on a Monday and Wednesday, so I know I'm not going to see my kids on those days. So for me, it's like I'm at work all day, all evening on Monday. So this is going to be the day where I head to the gym and just go for a quick swim, because I've lost my evening with the family anyway. So let me make the most of it and squeeze in some exercise. So I think it's really important to be flexible and to try and bring in exercise somehow into your daily routine. I think it's important for us, especially because we have to be able to look after our patients, and so we've got to look after ourselves as well, I think, to remain healthy and provide the best care for patients.
So exercise is the answer to everything, and leg day is extremely important.
Yep.
True. It's not just for your joints, it's for your health.
Yeah, I can hear. So is there anything else either of you would like to add before we finish?
To finalize, the foot is the mirror of the soul. The Chinese knew it already, because everything over the foot area is related to your organs and your whole capacity as a human body. So to answer that final question of yours, yes, the foot tells much more than just what people think.
That's really good to know, because I really hate feet, so I know who to send them to.
Very happy.
Well, the foot is the mirror to the soul. I've never heard that before, but
There
I'm
you
going to
go.
take that one with me.
There you go.
Well, thank you to both of you for a really interesting conversation today. I've learned a lot, really, really have, which has been amazing. And thank you to everyone for listening to Behind the Best. Don't forget to follow us and tune in for more stories and insights, because behind the best, there's always more for you to discover.